So Dr. Amit will be presenting on understanding barriers to cataract surgery, study on patients with bilateral mature cataract.
Good afternoon, everyone. Today I will be presenting on understanding barriers to cataract surgery. It is a study on patients with bilateral mature cataract, financial disclosures none, and conflict of interest none. Uh, Cataract surgery is one of the safest and the most predictable healthcare intervention. It is one of the most common cause of blindness worldwide. According to WHO, only 17% of the patients with cataract have access to surgery. Several measures have been undertaken under the NPCB in India, such as free cataract surgery in government hospitals and camps to identify and treat cataract blind patients, and mobile district ophthalmic units, which go to PHC and CHC and collect the patients and do the surgery. India has the highest cataract surgery rate, that is 65 lakhs cataract surgery per year. Aims is to identify the barriers of uptake of cataract surgery among patients with bilateral mature cataract. It's a prospective study, duration of 18 months. Study was approved by the Institutional Ethical Board, research added to the Declaration of Helsinki. All patients with bilateral mature cataract were included. Detailed history was taken, that such as age, gender, place of residence, rural, urban, occupation, literacy, or socioeconomic status, duration, comorbidities, and reason for not seeking treatment. Results, total number of patients which we included were 62 patients. Most common age group is more than 60 years of age, that is 72%, 77%. And females were most common among them. Literacy level and residence, most of them has no formal education, and majority of them were residing in the rural area. If we consider occupation and socio-economic status, 62.9% of them were unemployed and of low socio-economic status category. And duration, most of them presented with more than 3 months of duration, that is 3 to 6 months being the most common, and majority of them more than 3 months. And hypertension is the most common comorbidity associated. Reasons for not seeking early treatment, the most common was the fear of surgery, then transportation difficulties. If we consider among the males and females, fear of surgery was most common among females, and transportation difficulty was in males. Reasons for delay, if we consider between rural or urban, most of them were in a rural area, that is fear of surgery and transportation difficulty being most common. And lack of awareness in the rural setup. Old age, rural residents, low literacy levels, and low socioeconomic status, fear of surgery and transportation difficulties. These are our major barriers in our study. 3/4 of our patients were old. Prevalence of non-operative cataract were higher in elderly. Contributing factors were comorbidities and increased dependency. Rural residents, most patients were from rural areas. This is an agreement with the study by Lipi Chakrabarti. Most of the eye care facilities providing surgical treatment are located in town and cities. Low literacy level, less access to information, and poor utilization of services. Fear of surgery is the most common reason cited. It's an important barrier for cataract surgery and lack of awareness. Low socioeconomic status leads to financial issues. Most of these were unemployed or daily wage workers. Seeking treatment means loss of income for them. Transportation difficulties, which is most commonly cited from men. It's common barrier identified by rural residents. Contributing factors include limited public transport facilities and need for multiple visits to hospital for follow-up post-surgery. Slight female preponderance was seen, but it is not statistically significant. Female gender a barrier to access cataract surgery in South Asia, especially in India. Contributing factors were low literacy rates, low self-esteem, low expectation, and financial dependence. Cataract blindness can be reduced by around 6.28% if gender gap in cataract surgery coverage eliminated. Conclusion, it's an interchangeable factors, like everything is dependent on one another. If in low literacy level, it leads to lack of awareness and unemployment, and lack of awareness will lead to fear of surgery. In rural patients, there is a transportation difficulties, and in female gender, economic issues, no accompanying attendance. A multifaceted approach is needed to address the diverse nature of these barriers. Priority to improve awareness and accessibility in elderly, women and rural. Suboptimal utilization lead to wide disparity between those requiring eye care and those receiving eye care services. Barriers were Barriers for early uptake vary from region to region, hence need planning at the local level. All the advancements in cataract surgeries are meaningless unless there is the intended population. Availability of trained cataract surgery infrastructure for quality cataract surgical facility in rural area will reduce many barriers.
Next speaker can prepare themselves. In the meanwhile, if we have any questions, we can take. Okay, doctor, thank you. Next, UGH syndrome, a rare complication of glued eye weld by Dr. Kalpamoy Kakati. Is the speaker here? Okay. If not, we can move to the next speaker, Dr. Shantipriya. Is Dr. Shantipriya is here? Okay. Is Dr. Mohini Agrawal here? Dr. Mohini Agrawal? Dr. Varsha? Okay, Dr. Varsha will be speaking on imposters of posterior uveitis, a case series.
Good afternoon all. I'll be presenting a case series of the title Uveitis in Disguise. So case 1 is a 50-year-old lady presented with watering, pain and redness in her right eye since 1 week. Her best corrected visual acuity in both eyes was 6/9/6 and intraocular pressure in the right eye was raised with 28 millimeter of mercury. And on anterior segment examination, the right eye showed conjunctival congestion, shallow AC, and closed angles on gonioscopy. So when we examined the fundus, there was crowded disc and tortuous vessels with dull foveal reflex. She had earlier consulted in elsewhere and was diagnosed as right eye acute congestive glaucoma and was started on anti-glaucoma medications. She presented to us as there was no resolution in symptoms. When we examined the fundus carefully, we noticed that in the right eye there were choroidal elevations at the macula and in left eye there was hyperemic disc. We further advised OCT and we found multiple pockets of subretinal fluid with retinal pigment epithelium undulations, and ASOCT showed closed angles and a hyporeflective space in the ciliary body suggestive of ciliochoroidal effusion, and B scan was within normal limits. We further advised fundus fluorescein angiography and found multiple hyperfluorescent pinpoint dots temporal to the fovea with no leakage, and left eye there was disc leak. So we came to a diagnosis of both eye posterior uveitis, probably VKH, and we further advised investigation, the basic uveitic investigations, and all came to be within normal limits. So we advised oral prednisolone with gradual tapering. So 1 week post-treatment, the vision has improved to 6 parts with resolving subretinal fluid pockets and choroidal undulations. Coming to the case 2, it was a 45-year-old lady presented with blurring of vision in her left eye since 10 days, and she also gave a history of tinnitus. So her best corrected visual acuity left eye was 6/9/6, right eye was 6/6/6, and both eyes showed blurred disc margins with peripapillary fluid. She had earlier consulted elsewhere and was diagnosed as bilateral papilledema and was on treatment by neurologist with oral acetazolamide for IIH. When we carefully examined the fundus, along with the disc edema, we found choroidal elevations at the macula and subretinal fluid. And OCT showed thickened choroid with RPE undulations with the pockets of subretinal fluid. So we came to a diagnosis of both eye posterior uveitis, probable VKH, and investigations were within normal limits, and we advised oral prednisolone with gradual tapering, and 1 month post-treatment, vision was 6/6 in both eye, the disc edema had resolved, and the choroidal thickening had reduced and subretinal fluid was also minimized. Case 3 is a 39-year-old male presented with blurring of vision in his left eye since 15 days, and vision in the left eye was 612 N12, and on examination of the fundus there was subretinal fluid, and OCT showed neurosensory detachment. He was diagnosed elsewhere as left eye central serous chorioretinopathy and was given reassurance, but he presented to us as vision continued to worsen. And on careful fundus examination, we found there were multiple subretinal yellowish lesions in the macula with subretinal fluid. So along with the neurosensory detachment in the OCT, we found choroidal elevation, thickened choroid, and hyperreflective dots. We further advised fundus fluorescein angiography, which showed early multiple hyperfluorescent spots with late leakage and disc hyperfluorescence. So we came to a diagnosis of left eye posterior uveitis, and his MAN2, TB gold, and were positive with active lung lesions. So he was started with antitubercular therapy by pulmonologist, and we started him on oral prednisolone after 3 days. And 6 weeks later, we found his vision improved to 6.6 with decreased choroidal thickening, RP undulations, and his ellipsoid zone was restored. So in all these cases, there was misdiagnosis. The first case, there was celiochoroidal detachment, which caused acute rise in IOP, and it due to the inflammation of the VKH. In second case, VKH can rarely present as bilateral optic disc edema, so we have to consider it as a differential. In third case, there was overlap of symptoms and signs, which led to misdiagnosis. So my conclusion is posterior uveitis is a sight-threatening disease, and the clinical presentation can be myriad. So a high suspicion in atypical cases with detailed history, clinical examination, investigation become necessary in order to arrive at an earlier diagnosis and prevent the delay in treatment and therefore visual morbidity. Thank you.
Okay, doctor. Next will be Dr. Mohini Agrawal. Dr. Mohini Agrawal is there. Dr. Rajeshwari. Dr. Seema Rani. She will be presenting on atropine for rapid progressive childhood myopia, ARM study.
Good afternoon, sir. Topic of my may I start? Good afternoon, everybody. Topic of my presentation: atropine in case of childhood progressive myopia. Introduction: myopia has emerged as a worldwide public health issue and is one of the ocular conditions identified immediately priority by the World Health Organization. Although the prevalence of myopia varies by region, age, and ethnicity, it is a major cause of visual impairment in both developing and developed world. Although the various strategies have been tried for myopia control, including orthokeratology, bifocal contact lenses, specially segmented spectacles, etc., the atropine eye drops continue to be the most widely used. So next slide. So next slide, not working. Aims and objectives of my study: to assess the effectiveness of atropine 0.05% for myopia control among children who are documented myopic patient and have rapid myopia progression by more than 0.75 diopter per year. Methodology: all children aged between 6 to 12 years with myopia at presentation between -2 diopter to -6 diopter included, and children having documented myopia progression of more than 0.75 diopter in the preceding year and best corrected visual acuity of 20/60 or better. Any ocular pathology such as amblyopia, strabismus, or glaucoma, as well as a history of prior ocular surgeries or the utilization of myopia control therapies such as multifocal lenses, orthokeratology, or use of atropine eye drops prior were excluded from the study. It was prospective study and 40 children were enrolled in the study with a mean age of 8.5 plus minus 2.2 years and 45% were males. It was done in 1 year from November 2023 to December 2024. In results, this table shows comparison of mean SER and axial length during the study period. Total 40 children were enrolled. The mean spherical equivalent refractive error 1 year before starting atropine treatment was minus 3.53 plus minus 0.78 diopter. At baseline, the mean SER was minus 4.58 plus minus 1.03, which increased to minus 4.98 to plus minus 0.97 diopter after 1 year of atropine treatment. The mean myopia progression rate in the previous year of enrollment at baseline minus myopia at 1 year was minus 1.05 diopter plus minus 0.21 diopter. A significant reduction in myopia progression rate of minus 0.4 was observed. The mean axial length at baseline was 24.98 diopter plus minus 2.43 mm and it was increased to 25.21 plus minus 2.32 after 1 year of treatment. The change in axial length after 1 year of treatment was 0.23 plus minus 0.08 mm, which was found between the change in axial length and change in SER. No change in distance as well as near visual acuity was observed at baseline and 1 year of follow-up. And the adverse effect related to use of atropine among study subjects was neither clinically observed nor reported by any participant. This table showing comparison of mean myopia progression during the study period based on gender, age, and parental myopia. The study cohort was stratified into 2 age brackets, younger age 6 to 9 years and older age 10 to 12 years. Younger participants exhibited notably higher rate of myopia progression across all assessment points compared to their older counterparts. Nevertheless, no direct association was observed between age and the response to atropine treatment. Among children whose parents did not have myopia, the myopia progression rate was minus 1.03 plus minus 0.22 diopter in year preceding enrollment and minus 0.41 plus minus 0.14 diopter 1 year after treatment. Similarly, children with one or both myopic parents showed comparable progression and minus 0.4 plus minus 0.11 diopter 1 year after treatment. Our findings indicate the parental myopia did not influence the rate of myopia progression before or after treatment. This table showing the analysis based on treatment response to atropine. Myopia progression of less than 0.5 diopter per year was seen in 24 cases, 60% of all cases after 1 year of treatment with atropine 0.05%, while out of 16 out of 40 cases showed myopia progression of more than 0.5 diopter. No direct correlation was found between treatment response and baseline refractive error. Refractive error of 0.43 and p-value was 0.11 and between treatment response rate of baseline progression. A moderate correlation between the rate of progression and baseline myopia refractive error was observed. It was observed that response to treatment was independent of the age at baseline, baseline refractive error, baseline rate of progression, gender, and family history of myopia. Conclusion. Our study concludes that atropine 0.05% could be an effective treatment for children with rapid progressive myopia with no significant side effects. Thank you.
So next presentation is Dr. Vishnu Teja. He'll be presenting on, please note it's time for EMR, ways to make use of EMR in ophthalmic practice. Over to you, Dr. Vishnu.
Thank you. I'll be presenting on role of electronic medical records. I'm Dr. Vishnu, consultant at Modern Eye Hospital, Nellore, Andhra Pradesh. My co-authors will be Dr. Chinmay and Dr. Bharati from Modern Eye Hospital. I have no financial disclosure. Today I'll be discussing on the role of EMR, the available EMR now, and the clinical and financial impact of them, and I'll conclude. Then coming to the digital revolution of in ophthalmology, we know how electronic medical records play a very role in day-to-day life because the challenges we face every day with the increasing of the patient volumes, the complex documentation which we require, and the integrated care coordination. And so the current challenges will be all the paper-based record issue, right from the medical records department where we need to fetch the case sheets, or if we need to attach any case sheets or to refer back the old case sheets will be very time consuming. And when we want to audit by any medical audit or clinical audit, we want to do the data collection, and again the data processing analysis will be again cumbersome with the paper-based data, and the integration challenges are again there. So just giving some examples of the current available electronic medical records in India. So this includes many of the softwares which are currently being used in many of the institutes in especially southern India. So right now I am using EHNote, and I have exposure to iNotes as well. So I'll be specifically talking about EHNote, which I am mostly using. So this is a cloud-based electronic medical record. So it has got many subspecialty templates and international classification diseases, and continued program training coding also is there, teaching. And it has integration with many of the ophthalmic equipment where we can seamlessly get all the images in one page. And the other benefits include enhanced clinical documentation, integration of the images, and the patient outcome tracking and follow-up management. So again, the financial part, we have a matrix of all the details which I'll be showing in the next few slides. And coming to the pharmacy thing, we have a digital prescription system which is possible with all the electronic medical records, and in specific to the EHNote, I'll give you an example where we need, with the current guidelines, with the current NABH norms, we need to always show the generic name. So if you want to give a getafloxacin, this should be coming for the prescription part. So and for me to know about the stock of it and the price of it, everything should be come in detail here. And again, the route of administration, everything is clear in this. And when we want to taper any medicines or tablets, the details should be again very specific, very clear to the patient, and also in their own language. So considering my state in Telugu language, so when I want to do Predfort, I don't want the patient to again confuse. So every details of every time, like for how many days, how frequently, and in the space provided, we can again write the details of the dates in detail if required. And again, the follow-up is very clear again. And in the same way, again, if you want to add any instructions like having any blurred vision or photophobia with any homatropine or any drug allergies to any specific medication or no allergies, that also we can add in the remarks of each drug there itself. And medication safety and cost control will come across. So again, as I said, it's very useful in auditing, especially medical audit, clinical audit, which are very mandatory in NABH, and it helps it again compliant to NABH accreditation and the medical council compliance, and the quality monitoring, and it helps in clinical outcome measurement, and it also helps in the patient satisfaction tracking. And this how the first page right from the login starts in EHNote, the left one which shows our login, and then at the registration before it comes to us, so it will be showing the options like whether the patient is an walk-in or online appointment by our website or a phone appointment or so. And once we enter the patient details, we can also tag the patient, how important or how early we should see the patient, whether it's an emergency patient or injury patient or so, or a wheelchair patient or vulnerable or triage patient. And this is how we see in the left column all the details, and the triage, wheelchair or emergency. And in the same way, we can see if the patient is referral, we can see from a school camp it's coming. And this is how we track the patient in every station, like at the optometrist, at the doctor level, dilatation, how much time the patient is spending at every station, so that when we want to do a clinical data also, this helps. And if we want to know if the patient is suffered or anywhere stuck anywhere also, we'll see by the timing, color change in the timings. And this is how the image integration happens, right from the fundus image, right eye, and then OCT macula, and the other image, and in the follow-up also, wherever there is attachments, we can see the file attachment symbol. And for the IP case, it's also the same thing, right from the checklist, we can see everything marked And in the intraoperative notes also, we can have the batch number of each and every lens, and again all the consumables, so that we can also integrate with the inventory, pharmacy inventory, so that everything which is deducting and each batch number, when we want to recall itself also, it's very useful. The case details, the number of cases, time taken, assisting sister, every detail is very useful in this way. And again, when we want to follow up of the patient, we can give a prior appointment, so that next time, 1 week down the lane, I can understand how many patients are there for me to see post-ops on a specific day. It's very useful to find out. And this is the same way in the inventory, what all IOLs we are having and what all medications we are having, and how many numbers are there, everything detail we can know. And in the pharmacy, coming to pharmacy, it gives us the details about the refrigeration, which are all the high-risk medications and lookalike, same-alike medications. And if at all any short expiry medications are there, here in the down page, we can see, and then we can exchange it or make use of them. And insurance also, it helps us in many ways, like getting the approval and issue and claiming everything. And this is the overall dashboard where we can, once we click, we can find out the detail of every number of outpatients and the revenue generated, and same wise investigations, pharmacy, opticals, where not. So I conclude, so it's a cloud-based service, not only EH Note, all other electronic medical records. It gives a real-time view of the overall OPD patients, appointments, the number of checked in, and also the date and month-wise the pharmacy revenue, everything. And this mainly satisfies the patient, where they get a clinical detail right from their diagnosis, procedures done, what all medications they have been given, that too in a legitimate manner. And it also helps the doctors. Thank you.
Thank you, Dr. Vishnu. Dr. Vishnu, I have a query. Like, these must be paid platforms. Do there is any option of any free platform, like for the government sector?
Unfortunately, madam, like whatever we have come across which are very useful, feasible for us, all are like in the paying side only. Maybe considering the more volume in government, maybe they can consider a better price. But still, I think it's a challenging in government sector.
Thank you.
Good afternoon, judges and my dear colleague. I am Dr. Lalit Sachdeva, Assistant Professor at Dr. S.S. Tatia Medical College. I am presenting on the prevalence of ocular manifestation of vitamin A deficiency among the preschool children in tertiary care hospital. Conflict of interest is nil. I would like to thank my faculty members and colleagues and all working staff. In introduction, vitamin A deficiency remain a significant public health concern, particularly in the developing countries, leading to preventable childhood blindness and other ocular manifestation. This study aimed to determine the prevalence of ocular manifestation associated with vitamin A deficiency among the preschool children attending a tertiary care hospital. It has been long be a nutritional problem of public health significance in India, and continue to be so even though the National Vitamin A Prophylaxis Program has been in operation for more than 3 decades. Methodology include type of studies, cross-sectional study, sample size is 140 patients, study population is children aged 1 to 5 years of age, and duration of study is 6 months from 1st February 2025 to 31st July 2025. Assessment tools include the detailed ocular examination were performed to identify the signs such as night blindness, conjunctival xerosis, bited spots, corneal xerosis, and keratomalacia. In the inclusion criteria include the patient less than 5 years of age, and patient detected with vitamin A deficiency, and patient giving informed consent to participate in the study. Exclusion criteria include the patient less than 5 years of age, patient on vitamin A treatment, and patient with any other vitamin deficiency, and patient refusing to give any consent. Result include in the gender-wise distribution, total patient is 140, males were 85, that constitute the 60.71%, and female were 55, that constitute the 39.28%. The prevalence of the ocular manifestation, there are 10% ocular manifestation are present in the total population. In the ocular manifestation, 50% are shown with the night blindness, and 20% shown with the conjunctival xerosis, and 30% shown with the bited spot. In the discussion, it is higher prevalence was observed on the children aged 3 to 5 years of age, that is 12%, compared to age 1 to 2 years, that is 8%. Ocular manifestation are more prevalent in the children from lower socio-economic background, that is 50%. Prevalence were more with those inadequate dietary intake of vitamin A rich food, that is 18%. In the measure in these studies observed that 37% population prevalence of the vitamin A deficiency among preschool children, which is higher than the present study. And Mulit et al. In the tribal children from the southern India reported 10% prevalence of vitamin A deficiency among the 1 to 8 year of children. And the last study include the 11.1% children to have the malnutrition in their study. In the conclusion, the finding highlight a notable prevalence of ocular manifestation of the vitamin A deficiency among preschool children in the studied setting. Targeted intervention include the vitamin A supplementation and nutritional education as essential to address the public health issues. And further research is warranted to explore the underlying cause and to develop effective prevention strategies. These are references. Thank you.
Thank you, Dr. Lalit. Next is mine.
Good afternoon, everyone. My topic for presentation is spectrum of ocular morbidities in geriatric patient attending a rural hospital in Punjab. Ocular morbidity is a major cause of visual impairment among the elderly. Geriatric population is highly prone to preventable eye diseases. 13% of Indians are more than 60 years of age. Risk rises after 40 years with sharp increase after 60 years. Rural areas with limited eye care facilities. According to the NPC, initially its aim was to reduce the blindness to 0.31% by 2000, which have changed recently to the NPCB and visual impairment, which target the 0.25% by 2025, which focus on urban strengthening and rural outreach. So the aim and objective of my study to assess the spectrum and distribution of ocular morbidities among geriatric patients attending a sub-district hospital in Punjab. This population-based cross-sectional study was conducted over 6 months at a rural sub-district hospital in Punjab retrospectively, analyzed the records of 447 patients aged 60 years or older for December 2024 to May 2025. The study included records of 894 eyes of 445 patients available with NPCB department. Detailed information about the presence of ocular complaints, past history, family, and history of any systemic disease were recorded. Unaided and visual acuity were recorded with Snell E-chart. Presenting visual acuity between 6 by 18 and 3 by 60 in the better eye was defined as visual impairment, and presenting visual acuity less than 3 by 60 in the better eye was defined as blindness. Anterior segment examination was done using torchlight and slit lamp. Fundus examination with undilated pupil was done for all subjects using direct ophthalmoscope. All patients with history or clinical findings suggested of retinal disease or glaucoma underwent dilated fundus examination. IP was measured with Shaw's tonometer in subject with glaucoma history and family history or suspicious of optic disease. The results were the age and gender distribution of the subject is shown in below table. The maximum number of subjects were in the age group of 60 to 69 years of age group, which was 279. Out of 447 subjects, 19.1% were diabetics and 32.5% were hypertensive. Visual impairment and blindness were seen in 31% of subjects and 8% respectively. There was a statistical significant relationship between increasing age and the number of visually impaired and blind individuals as shown in the below table. Out of there was no statistically significant difference between distribution of visual acuity according to the gender in our study. The most common cause of blindness in our study was cataract, accounting for 34.4%, followed by corneal opacity 30.1%, glaucoma 10.1%, and refractive error 8.2%, with diabetic retinopathy 2.7%, ARMD was 2.8%, and retinal detachment 2.8%, and other ocular morbidities were 8.9%. Among the various causes of visual impairment, the most common ocular morbidity was cataract 43.17%, followed by refractive error 33.11%, with pterygium 3.57%, with corneal opacity and degeneration was 3%, and glaucoma 2.68%, diabetic retinopathy was 1.34%, and ARMD 3%, and other ocular conditions were 12.23%. Population aging is a major global issue. India in a demographic transition with rising elderly population, which is 149 million in 2022, which accounts for 10.5%. In our study, the blindness was 8% and visual impairment was 31%. Similar studies reported the similar findings, and Singh MM et al. Reported higher prevalence of blindness, which was 12.2% with low vision 32%. Conclusion was ocular mobility in the elderly shows changing trend. Cataract refractor is still leading cause, needs short-term focus, but glaucoma and corneal disorders, emerging cause of irreversible blindness, needs long-term priority. Short-term strategies should address cataract and refractive error, and long-term efforts must target glaucoma, corneal blindness, and public education with early detection. Strengthening the primary eye care and community awareness and early detection and treatment with referral pathway can significantly reduce preventable blindness in the elderly population. Limitation was because it was single center study with small sample size.
Thank you, Dr. Jyoti.
Next is Dr. Syed. Dr. Syed Sohaib. Next, Dr. Vaishali. Okay. Next, Dr. Ruchi Madam will be speaking on ocular presentations in rare cases of congenital erythropoietic porphyria.
So very good afternoon, everyone. Today I'll be talking about the ocular manifestations in rare case of congenital erythropoietic porphyria. As you know, these porphyrias, they are a group of rare inherited disorders, extremely rare to the prevalence of 1 in less than 1 in 10 lakh of the pediatric population. They have autosomal recessive inheritance, and till now, all over the world, only about 280 clinical cases have been documented till now, and which mainly from the Western countries. In this disease, the clinical symptoms, they are caused by a homozygous defect of the enzyme uroporphyrinogen, which leads to the accumulation of biologically inactive porphyrins, mainly in bones, erythrocytes, skin, and teeth. As a result, due to the accumulation of excessive amount of these porphyrins, they induce phototoxic oxygen type of dependent damage in these tissues, leading to severe inflammation and followed by subsequent ulceration and scarring of all the light exposed skin areas. As a result, there occurs severe mutilation of hand, fingers, face, especially nose, ear, lips, and eyelids. Till date, only curative treatment, if done timely, is allogenic stem cell transplantation, and the only preventive measure is absolute 100% avoidance of sunlight. So I'm presenting a case of a 33-year-old male who presented to our department with the symptom of severe pain and redness in both eyes since 2 weeks, also associated with the foreign body sensation, burning, and dryness. Visual acuity, it was good, 6/9, and on examination, ocular examination, the right eye showed approximately 8 into 4 mm area of scleral melt, which was a recurrent scleral melt. Already he has this episode of scleral melt, for which scleral patch graft was done a year back. And in the right eye also, there was a 4 into 4 mm area approximately of scleral melt temporal to limbus with conjunctival congestion. On physical examination, there were hypertrichosis, hyperpigmented skin lesions along with mutilation of ear, nose, and fingers. On slit lamp examination, tear film breakup time was less than 3 seconds, and Shermer's test was severe dry eye, right eye less than 3 mm, left eye less than 5 mm. As we know, the clinical feature of this disease, it varies with the age of onset. If it's in vitro, it may present as non-immune hydrops fetalis. Postnatally, patient experience severe photosensitivity, while adults, they may suffer from severe skin lesions. So, we'll be talking about mainly the ocular complication, as I also saw this case for the first time, and I searched the review of literature, and it was seen that ocular complications, they are mainly nodular scleritis. It may be necrotizing type with inflammation or scleromalacia perforans. And these necrotizing scleritis and scleromalacia perforans, they are the most commonly reported ocular complication. The exact mechanism of this pathology is not known. The study by Takamura et al., they have revealed there were levels of porphyrins in the teardrops of these patients, which may be the precursors. And the sunlight, it triggers inflammation by activating these porphyrins. Thus, a combination of these accumulated toxic metabolites, along with the increased porphyrin, they may be exposing the sclera to necrosis and melting. Thus, eye is particularly susceptible to the photo damage. If it is in the cornea, it may also lead to corneal ulcer, subsequent scarring, ultimately resulting into blindness. Other ocular complication may be seborrheic blepharitis, keratoconjunctivitis, sclerokeratitis, cicatricial ectropion. And the photomutilation of eye can destroy the eyelids, which further exacerbates the ocular damage. So our case, it exhibited a scleral melt, which indicates long-term UV damage. So the management, it includes a multidisciplinary team approach. The curative is the bone marrow transplantation. The other, what we can do is we have to focus upon patient about the rigorous avoidance of sun and light exposure, and advise them to use sunscreens, okay, but they are not the substitute for strict light avoidance. And protection of eyes with wraparound sunglasses is must. If these ocular complications are seen, they should be addressed aggressively. Corrective eyelid surgery, use of steroids, both topical and systemic, to control the inflammation. And when needed, scleral patch graft, that is mandatory. So, and along with the systemic management of the blood transfusion, splenectomy, as and required by the hematologist. So I want to conclude that it highlights the importance of awareness about the ocular complication which may occur in these cases, as it is a rare disorder. So the treating physician should also be aware of the ocular complications, so that timely reference can help in the accurate diagnosis and prompt treatment of the patient. Thank you.
Thank you, ma'am.
We are done with the session.
Yes, yes. Ma'am, a small question regarding your talk. Is there any way, if we diagnose the case earlier, would it be helpful to the patient?
In preventing the permanent damage. So first is awareness, as this was a rare entity I have seen in this 15 years of my career. I was seeing it for the first time. So we must be aware about such diseases, and we should have also discussed with these dermatologists about these, if such type of ocular complication can occur. So as usually these type of patients, they first present to the dermatologist, so they should be referring these patients even with the smallest of the complaints, or before that also, for the preventive measures.
What other apart from blood investigations, any other ways to diagnose the condition, madam?
Any other ways to
I think
diagnose
dermatologist will help us also.
Yeah, they have to check the porphyrin levels in urine,
yeah,
and all this blood and this feces.
I think the prognosis is poor in all those patients.
Yeah, even this patient, he has undergone the bone marrow transplantation too, but that too failed.
Okay. Okay, we have come to the end of the session. Before concluding it, are there any speakers who are there? Dr. Kalpamoy, Dr. Shanti Priya, Dr. Mohini Agrawal, Dr. Rajeshwari, Dr. Syed Sohaib, Dr. Vaishali? If not so, then we can conclude this session. Okay, thank you.
Thank you very much.